tonight.
Many Nobel Prize winners. We are famous for Nobel Prize winners. As you can see on these funny pictures on the right, you see me with one of my friends. He is also a Nobel Prize winner. He has invented a new microscope. Stefan Hell is his name. And also we have people like Otto Hahn, who has invented the nuclear fission, which did not bring so much happiness to the world, I have to say. And the next, push the button again. Next, please. Yes. And also the bell curve, which is very important in psychiatry, was invented in Göttingen about 200 years ago. Next, please. This is the bell curve, which is very important for statistics and also for clinical studies. The next slide, please. There are many phobias, and as you can see, we have these funny phobias like allium phobia, fear of garlic, which is very common in Turkey, I have heard, and also aulophobia, fear of flutes, and fear of beautiful women, and piladophobia is the fear of bald people, and arachibutyrophobia is the fear of peanut butter sticking to the roof of the mouth, and hippopotamonstrous equidalia phobia is the fear of long words. That means, but these funny phobias we do not see every day in our department for anxiety disorders. Next, please. These are main anxiety disorders. We have specific phobia. One of the very common phobia is spider phobia, also in Germany. Although there is no spider that is dangerous, everybody is afraid of spiders. But these people do not come to our department because they are afraid of that someone would laugh. The psychiatrist could not help them with their simple phobias. But we see many patients with panic disorder. This is the main diagnosis that we treat in our department. This is also very often combined with agoraphobia. And then we have generalized anxiety disorder, social phobia, and separation anxiety disorder. Separation anxiety disorder is a new disorder. It's not quite new. It was in the DSM before, but now you can diagnose this in adults. This is new in the DSM-5. Next, please. Panic attacks, you all know, I don't have to explain what panic attacks are. Panic attacks, where you have all these symptoms of a fear of flight reaction, palpitations, chest pain, dyspnea, feeling of choking, fear of losing control, fear of going crazy, fear of dying, hot flashes, cold chills, dizziness, feeling of fainting, dry mouth, trembling, paresthesias, or depersonalization or derealization. Next, please. This is a scale which I developed many years ago, which was also translated into Turkish, which was also used in some papers written by Turkish psychiatrists in clinical studies. It's the Panik ve Agoraphobie ÖCI, and there you see questions like, concerning panic attack and shiddet and everything. You can read this better than me. And also we have some questions regarding agoraphobie. Next slide, please. There has been a little bit of change in generalized anxiety disorder in the GAD. In GAD, excessive anxiety and worry, more days than not, for at least 6 months. Difficult to control worry, and 3 out of 6 symptoms. Restlessness or being keyed up or on edge, easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance, and significant distress. So there are no major changes in the DSM. And the difference between panic and GAD is that with panic disorder you have these sudden panic attacks, but with GAD you have the same symptoms like restlessness and heart beating and dyspnea, but you can have this the whole day and not like in panic disorder in attacks. Next, please. And then we have social phobia, which is the fear of being criticized by other people and being in embarrassing situations or in situations where in the center of attention, like when you're giving a speech. Next, please. So, in search of the reasons for anxiety disorders, many research was done in the last years, and you know that genetic reasons are very important, and also neurobiological reasons, and also psychosocial reasons of panic disorder or other anxiety disorders. So we have written 2 papers on the biological markers in anxiety disorders, and we invited many of the famous anxiety researchers of Europe and the world for writing this paper. And the first paper on the left side is it's so-called Biological Markers for Anxiety Disorders, OCD and PTSD, a consensus statement, and part 1 is on neuroimaging and genetics. And on the right side you see part 2, it is on neurochemistry, neurophysiology and neurocognition. And now push the button, please. Yes, and below you can see that the summary of these 2 papers, it's very short. Despite extensive research activities in neuroimaging, genetics, neurochemistry, neurophysiology, and neurocognition, no specific markers for anxiety disorders have been found yet. Only serotonin seems very important still with regard to treatment. Improvement of serotonergic neurotransmission seems to have the best body of evidence still. So nothing new was found in these papers, although we studied like all around 2,000 research papers for these writing this review. Next, please. Now we turn to the treatment of anxiety disorders. There are many drugs available that have been studied in randomized controlled trials. On the left side, you see first-line drugs, like the group SSRI, which contains 6 different drugs: citalopram, escitalopram, fluvoxamine, fluoxetine, paroxetine, and sertraline, and the SNRIs, duloxetine and venlafaxine. And then we have a calcium channel modulator, which is pregabalin. On the right side, you see some other medications which were also shown to be effective in anxiety disorders. We have the atypical antipsychotic quetiapine, then the tricyclic antidepressant clomipramine and imipramine. Then we have a drug opipramole, which is not available in Turkey, as I think. And some benzodiazepines like alprazolam, clonazepam, lorazepam, and the MAO inhibitor phenelzin. And other pyrones like buspirone, there's only one, moclobemide, and according to new studies, lavender oil was also effective in anxiety, and the antihistamine hydroxyzine, which is an old drug, but is not used quite often. And also agomelatine was studied in some patients with generalized anxiety disorder. I will show you the results later. So you see some first-line drugs which can be used, and many other drugs that you can use in case of non-response to the first-line drug. Please, the next slide. So all these drugs have advantages and disadvantages. The SSRIs and SNRIs, they do not cause addiction, and they're safe in overdose. But disadvantage is that they have a latency of 2 to 6 weeks until the drug starts to work. You feel jitteriness, which is some kind of nervousness, nausea, and sexual dysfunctions and other adverse events. And then we have pregabalin, which has a fast onset of action. It was only licensed for generalized anxiety disorder. The drug is quite different from the SSRIs because it causes somnolence, dizziness, and other adverse events. And that means people can have better sleep with this drug. You don't have insomnia like with the SSRIs and other drugs. But there have been some reports of people having overdoses with pregabalin. So some people thought this drug could cause addiction, but we do not have evidence for this opinion. Then we have some other drugs, the tricyclics. They also have this latency of 2 to 6 weeks, and anticholinergic or cardiac events, weight gain, and they may be toxic in overdose. The benzodiazepines have a fast onset of action, but they cause dependency and prolonged reaction time. Moclobemide doesn't cause addiction, has a latency of 2 to 6 weeks, and lower effect size than the other drugs. You need a higher dose until you have the same efficacy with SSRIs. And it's only licensed for SAD, and the studies were inconsistent. That means some studies did not show difference to placebo. Buspirone doesn't cause addiction, has also the latency of 2 to 6 weeks, low effect size, only for GAD, causes somnolence, but not very often, nausea and some other adverse events. Okay, next slide, please. There have been some guidelines for anxiety disorders in the last years. One was written for the World Federation of Societies of Biological Psychiatry guideline. This is already from 2008, and this was the first revision. I'm going to write the second revision in the next year. And United Kingdom had the British Association of Psychopharmacology had also a very well-known guideline by David Borwin. I was also involved in this guideline. And in Germany we had a guideline recently, 3 years ago, which is very similar to the other guidelines. That means most of these guidelines have the same opinion. Please go to the next slide. Yes, this is from the World Federation of Societies for Biological Psychiatry. In the first dark green line, you see the best drugs for anxiety disorders are the SSRIs, like sertraline, paroxetine, and SNRIs like venlafaxine and duloxetine and pregabalin. Then on the side of psychotherapy, on the right-hand side, CBT has the best body of evidence. In the next line, we see some drugs that have sufficient evidence, but a limited risk-benefit ratio. All these drugs have some problems, like quetiapine is not licensed in most countries for anxiety disorders, only for schizophrenia and depression. And also tricyclic antidepressants have more side effects than the other drugs like SSRIs and SNRIs. The benzodiazepines can cause addiction, and the MAO inhibitor phenelzine can also cause some severe interactions with food or with other drugs. And then the yellow line, you can see drugs that have positive but insufficient evidence. That means some of the studies were not showing any difference to placebo. Or for opipramole, there's only one positive study. So this is not enough to recommend these drugs as regular drugs for the treatment of anxiety disorders. And also exercise, which was running 3 times a week for 5 kilometers, was shown to be effective, but it was not as effective as a drug. So this could not be the only treatment for an anxiety disorder. And for psychodynamic therapy, we found inconsistent evidence. There have been some studies in the recent years showing that it was not very effective. It was in one study even less effective than the control group, and in most studies it was less effective than behavior therapy. We have no evidence for herbal preparations. There's one exception, lavender oil. I will show you on one slide later. And autogenic training. Okay. Now we have the question, which is the best drug for an anxiety disorder? There are only few studies which directly compare two drugs, like 2-SSRI or an SSRI with an SNRI. And mostly these studies are underpowered. That means the sample size is too small to prove that one drug is more effective than the other. For such a comparison, around 200 patients per arm are needed. This is, most people do not know that, but when you have a study where you have maybe 100 people with sertraline and another 100 people with paroxetine, then you can only show that these two drugs are maybe better than placebo, but you cannot say sertraline is as effective as paroxetine because the sample number is just too small. So a better approach is to compare all existing studies with all drugs in a meta-analysis of pre-post effect size. Next, please. A pre-post effect size I will have to explain. Here you can see a slide with a HAMA, which is the Hamilton Anxiety Scale. And then we have a typical study with the drug. At baseline, someone has 24 on the Hamilton scale. And during treatment, this goes down to, let's say, 12 points on the Hamilton scale. And with the placebo, we start with 24, and this goes also down, but only to 16. So the difference between 12 and 16 is an effect size, which we call the treated versus control effect size. This is a small effect size because between placebo and drug, the difference is small. But if you look at the pre-post effect size, you just look what happened with the patient from the baseline to endpoint. And this is very important for the patient. The patient wants to know what happened with my anxiety symptoms. When I have 24 on the Hamilton scale, I feel very bad. And when I have 12, I feel much better. This is what the patients want to know. Usually, most meta-analyses measure the drug versus placebo effect size because we know that placebo is effective and we have to know whether there is a difference. But also, it is very interesting to look at the pre-post effect size. But this effect size, you have to know that it includes many factors. First, the true effect of the drug, then the placebo effect, then spontaneous remission, and also the tendency of regression to the mean. So when we measure pre-post effect sizes, we have to be aware that they also include all these unspecific effects. Okay, next please. Now this was the result of our large meta-analysis. We had 234 studies and almost 40,000 patients in these studies. And in the first line, you see SNRIs have an effect size of Cohen's d 2.25, and the SNRIs as a group were the best group for treatment of anxiety disorders, then followed by the benzodiazepines, 2.15, and then you see CBT and drug, but you have to be aware that CBT and drug is not better than SNRIs. Why that? Because there have been only 16 studies, and these studies did not use the best drugs. So this explains why CBT plus drug was not better than drugs alone. SSRIs were also in the same range, and you have to say that in the first group, all the orange dots, there are no significant differences. As you can see, all the confidence intervals overlap. That means there's no significant difference between SNRIs and TCAs with regard to, although the differences are numerically very different. But then you see the green dots are all psychotherapy. Relaxation treatments had the best effect size of 1.36, but this was much less than could be obtained with drugs, and also behavior therapy like CBT, which included cognitive behavior therapy and exposure as individual therapy had 1.30, and this was based on 93 studies. And this is quite surprising. If you go to the next line, you see pill placebo. This was based on 111 studies. And the pill placebo had also an effect size of 1.29, which is the same effect size as for CBT. This is quite surprising. But this is based on altogether 200 studies. That means it's very difficult to refute this hypothesis that both are the same. Group therapy was a little less effective, and psychodynamic therapy again less effective than CBT or placebo, and non-face-to-face therapy. This includes all internet therapies. Internet therapies had only 1.81. This was based on 34 studies. And the reason is maybe because some people do not like internet therapies, they like the real person better. It's like this presentation, it maybe look on Skype, but you would maybe prefer to see me there. So it's the same in therapy. It works not as good when you don't see the real person. And then we see the psychological placebo, which is the control group that is usually used in psychotherapy. That means someone, like a student, is talking to the patient without applying any different techniques that are used in psychotherapy. This is a very important control group, and as you can see, CBT is different from psychological placebo because the confidence intervals do not overlap. But psychodynamic therapy overlaps with psychological placebo. So we cannot say from this meta-analysis that psychoanalytic therapy is effective. Waiting list is much less. And this is why I always argue that we should not use any more waiting list control groups in CBT trials, because this doesn't show anything. This is like an open study. Everybody knows who is one group, there's no blinding, and also the effect size of waiting list is very small, so you always will find a difference to any kind of treatment that you investigate. Next, please. this is a list of drugs from our meta-analysis, and we included more studies, but on this slide you can only see the studies where we had at least 3 studies. And the winner was quetiapine. This is funny because this drug is not licensed in any country. And as citalopram was the next best, then hydroxyzine and lorazepam. You see some benzodiazepines. Then comes paroxetine with 2.42, which is still quite nice. Venlafaxine and pregabalin. And then we see this yellow line. This is the SNRIs as a group, sertraline, benzodiazepines, and SSRIs. We don't have to go through all these slides, but if you look down at the bottom, you see that buspirone and phenazine are less effective than the other drugs. This is also my clinical experience, and also like moclobemide and buspirone, they were shown not to be effective in some placebo-controlled studies. And I was happy when I saw this because I had treated my patients in the last 30 years with exactly these drugs that have achieved high effect sizes in the meta-analysis. That means also from my clinical experience, I choose the drugs after 30 years which worked. I never used fluvoxamine and buspirone very often because I had this experience that they don't work quite well. Okay, next please. Oh, you see agomelatine. I put this in because these studies appeared later. Agomelatine has 1.78 and is in between imipramine and clonazepam, which is not bad, but the effect size could be better, as you can see. Next, please. Drugs that have been recommended by guidelines and show high effect sizes, this is a summary of the last slide, are escitalopram, paroxetine, or venlafaxine, or pregabalin. So if you want to be sure that your patient gets better in about 8 weeks, then please take these drugs and you will have a high chance to see a success with these drugs. Next, please. But we have to take care of side effects. Like for SSRIs, in the first weeks of treatment, you have to take care that the patient doesn't stop the drug. Usually, a patient comes to me and says, please, doctor, don't give me any psychopharmacological agents. Please treat me with CBT. Then I say, yes, you can have CBT. You have to wait a little bit, a couple of weeks until we can find a place for you for therapy, but we can start with the drug right now. And but you have to take this drug regularly and not only once a week. You have to explain this to the patients. And also you have to be aware that there might be side effects in the first weeks. Otherwise, if I don't tell the patient, he might stop the drug and never appear again because he thinks the drug doesn't work. There are other side effects, and also some of these side effects can appear later. Also like sexual dysfunctions, which is a problem with SSRIs. Some of the patients take the drug for 3 or 4 weeks, then anxiety disorder gets better, but then they suddenly realize there was something we have to take care of. And the problem is that you have to stop the drug and take another drug, but there are not many drugs that are working well in anxiety disorders and do not cause this sexual dysfunctions. And when you stop a drug, you might experience withdrawal symptoms, but these are not comparable to stopping benzodiazepines. It's not an addiction that you cause, but you should just lower the dose, maybe from 2 to 1 pill and then to a half pill for 1 week. Take it slowly, and then you can get out of the drug easily. Next, please. Now, these are the dosages, and on the left side, you see the first-line drugs. We only take care of the first-line drugs. And so usually I start sertraline 50 milligram, and then I go up if it doesn't work after a couple of weeks. And escitalopram, you can go up to 20 milligram. There if you take care of side effects like QRS prolongation, which might be a problem with escitalopram, which is a pity that you cannot take a higher dose of over 20 milligram. With sertraline, if you have a patient with a heart condition, you can go up to 200 milligram, and it was shown to be effective also in patients with a bad heart condition. And also paroxetine is safe, and then you have the SNRIs, you can go up to 225 milligram. I often have to go up to this higher dosage because many patients with 75 milligrams do not get better, so please go up to 225. And duloxetine, most cases I need 100 milligram. Calcium modulator, pregabalin, you don't have to go up to 600 milligram, only maybe 300 to 450 milligram. Yes, and then we have some other drugs. We are not going through these drugs. You can see tricyclics, moclobemide, buspirone, and alprazolam. And below, at the bottom of the slide, you can see acute treatment of a panic attack. You can take sublingual tablets of lorazepam, 1 milligram or 2.5 milligram, and this will cure the panic attack within a couple of minutes. But usually, if you talk to, as a doctor, go to a patient and talk to him calmly, then he or she will suddenly get better just by seeing the doctor, and usually you do not need any drugs to stop a panic attack. Next, please. And this is a quite new drug. It is on the market since many years now, but is only licensed for depression and not for GAD. But there have been 4 positive studies showing that it works better than placebo, and also a low dose. The last study showed that also a low dose of 10 milligram was better than placebo. So we have 4 studies showing better efficacy than placebo, and but you can use this drug only off-label. Next, please. There is another drug. I'm not sure if it's available in Turkey, and it's called vortioxetine, and it's a very complicated drug, is a serotonergic agent, and has some funny receptor actions. You can read here, it's a little bit complicated, the receptor action. But the bad thing is that it was not very effective in GAD. Only in the last slide it was shown to be effective. Only in the last study by Borwin that it was better than placebo. All the other 4 studies did not show efficacy in GAD. Next, please. Oh, this is the same slide in a better version. I forgot to take out the first slide. So here you can see that it's just the same. Only the last study by Borwin showed a better efficacy than placebo. So this drug is probably not going to be licensed for GAD, but it's a very good drug in depression, and also in patients with depression who have anxiety symptoms. Next slide, please. Then in some studies, like in Germany and Austria, people like very much herbal preparations. Also, we use St. John's wort, and as far as I know, most St. John's wort that is produced in pills in Germany comes from Turkey. And I'm not sure about lavender oil, probably it also comes from Turkey. The lavender, I have it in my garden too. there have been some studies, but I'm a little bit skeptical because these studies showed, the first study showed that this was as effective as lorazepam, but this study was underpowered, and lorazepam was only used in 0.5 milligram per day, which is not enough. So it's no wonder that both drugs had the same efficacy, because the lorazepam dose was too low. And also the next study by Kaspar, paroxetine, showed only a trend towards significance, but also the dose of paroxetine was too small. It was only 20 milligram. And then there were some studies in subsyndromal anxiety disorders or restlessness and agitation. So altogether, I think we need more studies to show if this herbal preparation really works. Next, please. So when a drug doesn't work, which happens from time to time, like I would say between 20 and 30% of the patients, you will not have success with the first drug. Switching studies are lacking. That means we do not have only one trial of pregabalin in the switching studies, but all the other switching studies, like switching from an SSRI to SNRIs or to TCAs or vice versa, do not exist. That means we do not know if this really works. But what we are doing all the time in my department, we switch from one drug to the other. And we find that if you switch from one SSRI to another one, you also will see some success in many patients. And also can switch to other groups like SNRIs, or you can switch to pregabalin. Next, please. Now, this is a case vignette of a patient, and he is 20 years old. He is a motorcycle mechanic, and he suffers from sudden attacks with palpitations, chest pain, dyspnea, feelings of fainting, dizziness, fear of dying, paresthesias on the left side, fear of being seriously ill, and he also fears and avoids situations like crowds, parties, public transport. And the fear is not that other people could criticize him, but that he could get an attack of these symptoms again. So which diagnosis and treatment would you suggest? I can go to the next slide, please. Next, yes. Well, I guess that most of you would have said that panic disorder and agoraphobia is the right diagnosis. And which treatment would you prefer? Well, we have four choices: escitalopram 10 to 20 milligram, venlafaxine 75 to 25, or alprazolam 1 to 3, or propranolol, which is a beta blocker, 20 to 40 milligram. If you ask me, I would prefer number 1 or number 2. That means escitalopram and venlafaxine are very good drugs for this panic disorder. Alprazolam is only second choice because you can get addiction. And also, Mesut is a motorcycle mechanic. He has to drive on his motorcycle all the time, and that means he cannot be treated with alprazolam. This would be dangerous. Propranolol is a beta blocker, and beta blockers have shown that they are not effective in panic disorder. So take number 1 or number 2. Next, please. And if we have a patient with GAD, generalized anxiety disorder, the treatment could be very similar. We could use sertraline, we could use escitalopram, we could use venlafaxine or pregabalin. And also, it is recommended that you start with CBT, cognitive behavioral therapy. Next, please. And how long should we treat these patients? For an anxiety disorder usually has a waxing and waning course, like with panic disorder or GAD, and you have a low rate of spontaneous remission. That means when you treat patients with a drug, treatment should continue for at least 1 year to reduce the risk of relapse. And the problem is that there are no reliable predictors of who is at risk for a relapse. This is why we treat so long, because many people say after like 3 months, they say, well, my panic disorder is gone now, can I stop the drug? I always say, no, please take it for another half year at least, or better would be 1 whole year, because we cannot say if you don't have a relapse in the future. Next, please. And here you see Professor Gallagher's controversial method of simultaneously treating the fear of closed spaces, heights, and snakes. Next slide, please. Cognitive behavioral therapy for anxiety disorders was shown to be effective in 93 studies, and groups CBT in 18 studies in our meta-analysis. There are many more studies, but not all of the studies could be used in the meta-analysis. Individual CBT or exposure was significantly more effective than a waiting list, than a psychological placebo or pill placebo conditioned in our meta-analysis. However, group CBT was only superior to waiting list and not to a pill placebo, and not better than a psychological placebo. This is why individualized CBT is still better than group CBT, and also what my patients tell me when they have been in a group of, let's say, 10 people, they say, well, I didn't have the chance to talk at all because there were other people who talked all the time, so I almost fell asleep in the group CBT. It didn't help me at all. Next, please. And regarding exposure therapy, is it necessary that therapists supervise exposure in situ exercises outside the therapy room? That means, can you just tell the patient, go out? I tell you what to do, but I will not come with you. And this is what mostly happens. The psychotherapist doesn't have the time to go along with the patient to practice the exposure therapy. Next, please. But there was a study by Gloucester et al. It was done in Germany. Therapist-guided exposure was more effective than CBT without therapist-guided exposure therapy. That means it's always better if the therapist comes along. Like in this slide here, in this picture in the right corner, there's one therapist going on a church tower in my hometown and forces the poor patient to look down through the window. Next, please. And there are some other recommendations for CBT. Individual CBT is more effective than group therapy. I said this already. And exposure therapy is more effective than without exposure. Guided exposure is more effective than without therapist-guided exposure. And treatment should be guided by manuals, by books, and breathing retraining has no additional effect. And there is no evidence that longer treatments like 20 to 24 weeks are more effective than shorter ones like 8 to 12 weeks. These are some recommendations for CBT. Next, please. And when you compare medications versus psychotherapy, in most guidelines you will read, well, you should use CBT and then you can use drugs. And like in the British guidelines, the NICE guidelines, they say you should prefer CBT before you start with the drug. But according to our meta-analysis, this is, I think, a wrong recommendation, because we looked at many studies, like you can see, almost 40,000 studies. We look, and drugs were much more effective than psychotherapy. This makes a difference. Like drugs were almost twice as effective as psychotherapy, even the bad ones, because in this study we put all the drugs in, the bad drugs and the good drugs, and also bad psychotherapies and the good ones. But the 184 study arms were mostly CBT. So I I don't think there's much room to improve CBT than more than 1.22 effect size. Next, please. Next slide. Well, this is a study, looks very complicated. What we did, looked at what happens when you have stopped CBT or other psychotherapies. So we had a couple of groups. One was a placebo group, which is the red line, the black line is placebo groups. Then we have CBT, red groups. Other psychotherapy were green lines, and blue was drug therapy. We looked at the point where we stopped the treatment. So treatment was stopped, and then we looked at follow-up studies. We put all follow-up studies together in one computer, which made all these funny, beautiful dots on the picture, and we looked at many, many follow-up points and pooled all the results of these time points. That means we can now say what happens after stopping drug until 2 years after stopping a drug or stopping CBT or stopping a placebo. So next slide, please. The results were good news for the patients. CBT and other psychotherapies have durable effects. That means if you stop CBT, 2 years later, you have still the same effects like on the day when you stop the CBT. So you do not get worse. But the same applies for drugs. This was also good news for the patient, maybe bad news for the CBT therapists, because when you stop a drug and you look up to 2 years later, you still see the same effect. The patients do not deteriorate on drug therapy, and also under placebo conditions. When you stop the placebo condition and look later in the follow-up studies, you also do not see a deterioration. So these were not significant differences. The only thing that we could say that CBT has more durable effects than other psychotherapies like psychoanalytic therapy, but we cannot say that CBT has longer durations of effect than medications, because this is what many people say, but it's not true. But we have some limitations. The studies that we could included in this meta-analysis were very few, especially for drugs and placebo. We did not have enough studies. And some of the drugs used in the analysis were not the most effective ones. So if we would have comparison studies, follow-up studies with drugs, with the good drugs like citalopram or venlafaxine or pregabalin, then we would probably see a better effect for the drugs. So next, please. So I come to my conclusions. And the recommended drugs for anxiety disorders are first-line SSRIs, SNRIs, and pregabalin. Second-line tricyclic antidepressants. You can use benzodiazepines with some precaution. And pharmacotherapy should be combined with CBT. Effect sizes for pharmacotherapy are higher than for CBT. And of all the psychological therapies, CBT has the best body of evidence. So if you have a patient like Mesut, the motorcycle driver, and you give him a drug and pregabalin, citalopram, and you can stop. So I hear something. Okay, I come to my end of my presentation. So if you have questions, I will gladly answer your questions. Teşekkür ederim.